his chair. So thank you once again, and I request that the speaker for today, who is speaking on Ayurveda, would start delivering his lecture. Thank you very much.
Can I start now?
Yeah, sure, sir.
Okay. Thank you, Rangare sir. It's a great opportunity for me to talk about Ayurveda and our ancient system of medicine. So today I will deal with some of the important points. What are the things are there in Ayurveda for geriatric care? Those are the things I wanted to give, because it is not possible for me to cover the whole thing within 30 minutes, but I will try to cover some of the points which are very, very useful, because we need the help of pharmacy scholars, because many of our drugs are potent, but we don't have that much of scientific idea how to project it to the scientific platform. That's why I think today's talk will be more on inputs rather than research, because we have done many research, but I don't wanted to talk about these researches, because I just wanted to give many inputs which are available. Can you share my screen? Okay, thank you. So that's why I just wanted to talk on geriatrics in Ayurveda. So I just wanted to skip some of the slides, because time is only 30 minutes. So my special thanks to Joshi sir, because he has invited me for this conference, and really I am thankful to him. And I also thank Milind Parle sir, because he's online. I also thank Basavannappa sir, then Rajendra sir, and all other dignitaries on the platform. So I just wanted to, today my talk will be on Ayurvedic geriatrics, and I wanted to cover few important things. Which are the medicines available, which are the single herb preparations are available for geriatric research, first thing. Then I just wanted to talk about the concept of geriatrics in Ayurveda, where we are having two different concepts. We are having different promotive concept, we are having preventive concept, we are having curative concept, and we are having a sustainable concept also, because this is very important. Sustainable concept, we call it as Rasayana, because there are two schools of thought are there. So how to sustain and how to postpone the aging phenomena, this is called as Rasayana concept. This is also one of the important things we have to discuss, because in others system of medicine, these concepts are not available. That's why I just wanted to focus on these things. So this is only the status of the problem. In recent years, there are tremendous increase in the pace of human being around the world. Why it is very important is, in 1947, the lifespan of a Indian is 47, but in 2010 it is 76, and in Kerala it is 84. Why? Because we have done a survey in Kerala, why it is 84 in Kerala, why it is 78 in Karnataka, and why it is less than 70 in Bihar and Uttar Pradesh. The answer is that the Kerala people are following the lifestyles of Ayurveda. That is the thing. If you go to a restaurant, they will give you jeera water. They will not give you plain water. They will give you jeera water. If you ask them to, if you go to a restaurant and take a room there, they will give you some oil for massage. They will have, because all these lifestyle things they are following. That's why average lifestyle, average lifespan of a person in Kerala is 81, which is more than the national average of 74. So then we did some survey, why it is more in Kerala. So the answer is, today I wanted to tell these things are there. So WHO estimates about 22% of the whole population is in 2025 is geriatric population, and it is a major risk factor for many non-communicable diseases, because nowadays the government of India policy says NCD, where they says you have to give an integrated approach, because it is a policy statement of 2017 says that an integrated approach for geriatric population is needed, because in Ayurveda there are many things are told and we are not practicing, and we are getting many justification for that. I can give you some example. One is Chavana Maharshi's example, where he has taken the intervention and he became young. Because I'm not saying that these are all stories. These are all the incidents. I just wanted to give these things. And one of the research started in Jamnagar, whether this story is correct or not. They have started in 2006. We are having a concept that is called Rasayana therapy, because the whole Rasayana therapy involves many things. They have started according to the research inputs, and 2 persons have been given Rasayana therapy, and they followed the protocol, and because of that protocol, all the positive results came. So that's why these things are very, very important. So I just wanted to give inputs rather than the research updates. So because many of the participants doesn't know about the concept of Ayurveda. That's why I just wanted to highlight more on the concept of Ayurveda rather than going for research updates. And if any queries are there, you can ask me, because I can definitely give you the research updates. The process of what is aging, this is very, very important. So I just wanted to skip this slide. I will just at this time, I just wanted to tell that it is process of aging or the process of growing old. That's all. So these are the different terminologies are there for the old age, senility, senilium, senescence, all those are there. So why do we age? This is very, very important, because the aging has got not only the physical, the aging has got physical, mental, then cultural, then other phases also there. So we are not only just giving a medicine or just giving an intervention. We cannot say we are stopping the aging phenomena. It is not possible, because it has got multifaceted causes. So we have to think about all those things. That's why very, very important is that this one is the Adhyatmik Chintan. Adhyatmik Chintan is one of the important. That's why in Ayurveda we are having 3-fold treatment. One is called Yukti Vapashraya Chikitsa, where you will give the intervention. The second one is called as Sattva Chikitsa, where you are working on the mental health of the patient. The third one is called Daiva Vapashraya Chikitsa, where we are giving treatment according to his cultural background. We are giving treatment according to his Adhyatmik Chintan, and we wanted to give the traditional look to the treatment. So it is a holistic approach. That's why do we age? It is an Adhyatmik Chintan, where we say Punarapi Jananam, Punarapi Maranam. This concept is there, where if we believe in rebirth. I'm not telling that rebirth is an essential part of our this one, because the Ayurveda says that it believes in rebirth, where it says Karma Siddhanta and all those things. I will not touch upon these Siddhanta, but I just wanted to say why I have given this slide is that we are only giving some intervention, and we are telling that we are stopping the process of aging. It is not possible, because we have to go for a multifaceted approach, where the Yukti Vyapashraya, Daiva Vyapashraya, and Sattva, the physical entity treatment for physical entity, the treatment for mental entity, and the treatment for all other things. Social background is there, cultural background is there, then philosophical background is there, because we have to tackle all those things. Then only you will succeed in the treatment of the aged. And we are having research updates also. I will, if time permits, I will give those research updates also. Otherwise, I will share these research updates to you, because we have done some researches in our Ayurveda Research Center, Mysore. So on Alzheimer's, on senile dementia, many researches we have done with our postgraduate scholars, where we have tried to integrate all the things. So these are the things. That's why I have shown this picture. Why I have shown this slide is that there is a need for multifaceted approach rather than giving a medicinal approach or simple intervention approach. That's why we are not getting we have started one clinic which is called as Vasalya Clinic. Vasalya Clinic is nothing but where we are giving medicine in a very low dose, or we are not working on medicine at all, we are working on other social, behavioral, then the philosophical approach by which we are controlling many of the smaller diseases which did not to be given any intervention. This is very, very important. That's why a philosophical approach is needed, a social approach is needed, along with our physical and mental intervention. This is very, very important. They taking care of the patient, because 3 T's are very, very important in treating the geriatric population. One is we have to talk with them. We have to give a room to talk them, because if they express their views, 50% of their problems will be definitely, there is no need of a medicine at all. Then we have to touch. This is very important. Now, touching and talking is not at all possible. We are just, a patient enters the doctor's room, and by the time he enters, we will write all the investigation. We will ask him and give him a letter. Go and do the lab investigation. These things are not at all needed when we talk about geriatric intervention. So talk is very, very important. Touch is very, very important. If you touch in a beautiful way, by the touch only, 50% of the ailments will be vanished from the patient. So talk, touch, the last one is treatment. So 3 T's are very, very important when we talk about geriatric treatment or geriatric intervention. The medicine has got a little value rather than talking and the touching the patient, because we have to do a holistic approach rather than going for, because for this disease XYZ treatment is there, and take the medicine and you will be relieved of that condition. That is not at all possible in geriatric patient. That's why we should have a philosophical touch in terms of talk, touch, and treatment. Then only we will get beautiful result in geriatric population. That is my view. So the period since birth, because we when we talk about geriatric treatment, we should understand this concept: chronological age and biological age. I don't want to touch on this, but I just wanted to show this. These things are very, very important, because in Ayurveda we are having 2 different entities. One is called as Kalaja Jara, the age happening because of the time. One is untimely, because you are seeing 35 aged person will have a white hair. This is called Akalaja Jara. Wrinkles on his face. This is called Akalaja Jara. So this is very, very important. Chronological age and biological age. This is modern perspective. But in Ayurveda, we are having 4 different types of. One is called Sukhayu. One is called Dukkhayu. One is called Sukhayu. One is called Dukkhayu. One is called Kalaja Jara. One is called Akalaja Jara. Because we have to take all this in cognizance when we treat the patient. This is very, very important. These are mechanisms. I just wanted to show this slide. I don't want to talk about this. These are the things are available nowadays. We are having a primary hallmarks, because of primary hallmark which causes the damage. We are having antagonistic hallmarks, responses to damage. We are having an integrative hallmark, culprits to the phenotype. So these are the things which are known to. I just don't want to waste my time. But just these things are there. Why I am showing this one is these things are also there in Ayurveda. I just want to, when I talk about Ayurveda, these things will come. Just I wanted to show this slide. This is the theory of genomic instability theory is there. Telomere attrition theory is there. Epigenetic alteration theory is there. Loss of proteostasis theory. All those deregulated nutrient sensing is there. Why I am giving? I just wanted to brush on this. I just wanted to talk. I don't wanted to talk on this because these things are there in Ayurveda. When I talk about the Ayurvedic concepts, you need to know these things. That's why just I wanted to brush on this. I just gave a few slides here. So this is mitochondrial dysfunction theory, because of this mitochondrial dysfunction, aging phenomena occurs. So we are having senescence theory. So we are having stem cell exhaustion theory. So many theories are there. I just wanted. Now, before treating a patient of geriatric, this is very, very important. Can you consider the aging phenomena as a disease? This is the first thing. We should know this, because we should not treat aging phenomena as a disease. It is an irreversible phenomena. It is an irreversible phenomena. It is a physiological phenomena and it cannot be stopped at all, because before treating the aged people, we should know that everyone will get. That's why it is a physiological phenomenon. It's an irreversible phenomenon. It is not possible for any system of medicine. It may be Ayurveda, it may be Unani, it may be Yoga, it may be allopathy, any system of medicine. It is not possible to stop the disease. That's why it is not a disease at all. It is an irreversible phenomena. It is a physiological phenomena. But why we should talk? You can ask me, why you are talking, sir? If it is not possible to stop you, we can postpone it. We can postpone it. Then we can go for a quality lifestyle. This is very important. So my talk, I am not going to talk about, so we will prevent the aging. No, it is not possible. There are only two things are there. One is we can increase the quality of the life. That is the first thing. Or other one is there. It's very, very important. No other system has got this type of inputs where we say we can postpone the age. And we are having one of the greatest branch of science. It is called as ICHAR system. ICHAR is nothing but we are postponing the aging phenomena. It is also possible. We are using the natural drugs to postpone it. So today I will talk about this because the concept is that, so before I start this concept, no science cannot prevent the aging phenomena. It is a physiological phenomena. It is an irreversible phenomena. It should happen. It is happening. It is happening for each and every. That's why I said, Punarapi Jananam, Punarapi Maranam. So that's why I took the sloka where you cannot stop and we cannot consider as aging, and we cannot stop the phenomena of aging, but we can postpone it by natural remedies, natural herbs. We can do it. There are many herbs are available. Many herbs have told, and they have given justification. Now, we have seen in market, there are many Chyavanprashas there, and lakhs of people are eating Chyavanprasha. Still, they are not. It is not possible for them to postpone the aging. You can ask me the question. Why? That's why the methodology prescribed how he should take, when he should take, where he should take, what are the methodologies are available, and how he has to take. Because all these things, protocols are there in Ayurveda. If you take the medicine according to the protocol, 100% I will guarantee you that the post-movement will definitely happen. For that, they have given justification 5,000 years back. Those justification I will show you. And today we have done some researches in Government Ayurveda Research Center where we have shown the post-movement of the aged phenomena. There are two schools of thought. So the one school of thought says after 60, you have to take the medicine. One school of thought says, no, it is not possible. If you take the medicine at the age of 60, it is not possible. You have to take at the age of 45. That is called Purve Madhye Va. That is before starting the old age, you have to take the medicine. That's why I said when to take, where to take, how to take, what is the methodology. If you take the medicine according to methodology, then only it will work. Otherwise, because I have seen, if I go to the medical shop where they will prescribe, they will sell the Chyavanprasha, Ashwagandha, many medicines are there. The old people are taking, and they are telling that, sir, for last 5 years I am taking, I don't have any effect at all. For last 10 years I am taking, because they have not followed the rituals. Before taking medicine, you have to take, you have to cleanse your body. There is a special type of treatment, detoxification of the body. That is called Panchakarma. So you have to go for the detoxification of the body, because if you take the medicine along with your toxins, it will not work. There is a beautiful procedure. It is called as Panchakarma, detoxification of the body. The whole body will be detoxified using Panchakarma therapy. And you have to go for 108 days of detoxification therapy. After that, if you take the Rasayana drug, it will definitely help. Here what we are doing is that we are only seeing the advertisements in the TVs or magazines or print media, and we say, okay, Chyawanprash is available. I am 60. I have to take it. No, it will not work. If you detoxify your body according to the methodology, because methodology has told 108 days of detoxification has been clearly told how to detoxify the body. Because when you are giving some intervention, we are worried about four things. One is the status of your digestive, agri, we call it as digestive fire, the status of your digestive, then the power of the, we call it as bala of the body. We will say it is the power of the body, bala, because you should have some because the assimilation power to your body should be there. I can give you loads and loads of rasayana, but assimilation power is not there in your body. It doesn't have any effect at all. So we are worried about the digestive power, that is called agni. We are worried about the power of the body, assimilation power of the body, we say, that is called bala. Rogi bala, we call it as rogi bala, agni, rogi bala. Then status of his disease condition. If he is a diabetic, can you give a rasayana? If he is a cardiac patient, is it possible? We have to say what are the diseases he is having. So status of his disease. So we have to talk about that. Then how many days he have to be put on the rasayana therapy. This is very important. So let us open our treasure of rasayana therapy. So I will talk about these things now. So two things are motivated in evolution of Ayurveda. We are starting the Ayurveda concepts here because I have told slightly the allopathic concept. Now I will start my Ayurveda concept. One is Jara Chikitsa is there, treatment for the aged people. It is a special branch. Now we are having gerontology and all those things. But 5,000 years back, there is a specialized branch. It is called as Jara Chikitsa. When I talk about Jara Chikitsa literally means that the treatment given to the older people. The treatment given to the older people. What treatment you will do? You will say there are only two principles. One principle is called as promotive principle, where we can postpone the aging process. This is called promotive principle. Second one is called as preventive principle, and it is called as we will prevent it, but it is not possible to stop. That is called Jara, later changed to Rasayana. So what type of treatment you are giving? The treatment given for Jara Chikitsa is called as Rasayana. Concept of aging in Ayurveda, lots of inputs are available. More than about 5,000 verses will be available for Jara Chikitsa. Beautiful. So they have been, because for each and every part of your life, they have laid down the rules. So Balya, Yavana, then Balya, Brahmacharya, Yavana, then Sannyasa, then Vanaprastha. These are the 5 different ashramas they have told. For each ashrama, they have given definite rules and regulations. What lifestyles you needed for those ashramas. This is why when I talk about Vruddhavastha, it is the last span of the lifespan of a person where it is characterized by degenerative changes. We say in Ayurveda, Vatakshaya and Dhatukshaya. Degeneration, we coin in terms of Vatakshaya and Dhatukshaya. Dhatukshaya is tissue degeneration, and Vatakshaya, we are talking about the motor system, we are talking about sensory system, we are talking about locomotive system. All those comes under the ambit of Vatakshaya. So Vruddhavastha or Jiranavastha. So when we talk about Vruddhavastha, it is more than 60, then more than 70, we call it as Jiranavastha. For that, the medicines are different, where we will give less potent medicines. You see, 5,000 years back, our wisdom says that for 60 to 70, you are having a list of medicines where it is slightly potent, then less potent you have to give, and dosage also reduced. Beautifully mentioned. I'm really surprised. 5,000 years back, they have told about the dosage. the format of the different forms of dosage. They have talked about which medicine, which herb should be used, at what time, where, when, and how. These are the beautiful things, because we are not following it. It is unfortunately we are not following it. And please note that at those times, the normal lifespan of the person without antibiotic, without these diagnostic things, at that time, in Treta Yuga, it is 300 years. In Kali Yuga, it is 120 years. When Charaka Sushruta written the document, they said the lifespan of the person is 120 years. That is full life. So this is beautifully, that's why they said, so 60 years, 120, they said 60 years, after 60 years, you have to follow, because keep it in mind of 120 years. Now the lifespan is 80, so we have to start at 40. At that time, it was 120. That's why he said you have to start at 60. Now it is 80. So we have to start at 40. We should be very careful on our lifestyle. There are many modalities told. Daily regimen, we call it as dinacharya. There are the rutucharya is there. So according to the season, you have to do some lifestyle. So Rutucharya is there, Dunacharya is there, Yoga is there, Dhyana is there, Pranayama is there, Mudra is there, and you will have a tailor-made. If it is not possible for you to walk also, you can do it from Mudra. That's the beautiful beauty of the Ayurveda, where in Yoga, because all those things, it is not possible for you to walk at all. Don't worry, you can do it with Dhyana. That's why the treatment is tailor-made according to your status, according to your disease, according to your age, according to your region. That's the beauty of the Ayurveda, where he says that. So that's a beautiful thing. So 60 years, what type of medicine? 70 years, what type of medicine? After 100 years, what type of medicine? All those things are documented, recorded. All the things are available for us. But I'm very sorry to say we are not using it. Type of Vruddhavastha, I have told about Kalajajvara, proper aging, Akalajajvara, premature aging. So after 60 years of age, called as Kalajajvara, it is Parikarshana Krita, that occurs proper age even after following proper regimen. That's why I said it is irreversible and physiological phenomena. You cannot stop. That's why he says that it is Parikarshana. Parikarshana means it occurs at proper age even after following. If you follow all the regimens, you can take whatever the regimens you follow, still it is physiologically, it is happening. You cannot stop it. Then Akalaja, this is you say, if you are not following the regimens clearly, aging will come early. This is called premature aging. Now we are getting it because we are not following it. We are not doing Dinacharya, we are not doing Ritucharya, we are not doing Dhyana, Yoga, nothing. That's why we are not following the lifestyles which are prescribed for each age. Balya, what type of lifestyle you have to do, what type of food. That's why when I talk about lifestyle, we are classifying lifestyle into ahara, vihara, vichara. This is very important. The thought process also very, very important. Thought process. Ahara, vihara, vichara. This is very, very important. We are not following. That's why when I talk about the geriatric intervention, it should be a holistic approach rather than going for this disease, this drug, this disease, this drug, this disease, this drug. No, that's why nowadays, if you go to a physician, he will write 10 to 15 drugs and the more than your food, double the quantity of medicines one is taking. Big box of medicine will come when you take breakfast. Big box of medicine will come when you take lunch. Why? Because we are only talking about disease and the treatment. We are not worried about other aspects. So my concern here is that we have to give a multifaceted approach. Then only geriatric intervention will be a successful thing. That's why we have to follow the 3 T's: talk, touch, and treat. This is very, very important. So aging is a natural phenomena, inevitable phenomena, physiological phenomena, progressive biological phenomena. This is not allopathy. This is Ayurvedic science told things. One is natural phenomena, one is inevitable phenomena, one is physiological phenomena, one is progressive phenomena, one is time-bound phenomena. This is very, very important. 60 to 70, what type of treatment? 70 to 80, what type of treatment? 80 to 100, what type of treatment? Progressive phenomena. The treatment depends upon progression of aging. So dosage, the medicines, the other intervention will depend upon other factors. Factors are very, very important. That's why in Ayurveda, factorial approach is very, very important. Factorial approach. You cannot give same drug for the same patient for the advanced age. No, it is not possible. Treatment has only 10% effect. This is not the word told by me. It is told by the acharyas, where they said 10% results can be. 10% means SS will be less. That is what told. That means 10% of the results you can. If you get a 10% of result, it is 100% of result. That is important. So why to worry? Because it is multi-systemic damage. So these are all the things. Nervous system, what type of damage? Respiratory, skeletal, digestive. I don't want it to talk about because time is less for me. So this, it is a multi-systemic. Our approach should be a multi-systemic approach, because what happens is, nowadays what happens, if aged patient has to visit to his physician, he has to go to a cardiologist, he has to go to a pulmonologist, he has to go to a urologist, all those things, and each one will write 3, 4, 5 drugs, and by the end of the day, he has to take 40, 45 type of medicines. So we should have a holistic approach. So it is not possible, it is very easy because all the things are there, but we are not following it. So a holistic approach, we should go for a holistic approach rather than we are having a breakaway approach. For heart, one doctor, for lungs, one doctor, for kidney, one doctor. No. Such things are not at all possible because the whole body has been injured. And if you go on giving the breakaway approach, he should go for at least 30 doctors because each organ has got a doctor. This is not an approach. Breakaway approach is not at all possible. A holistic approach is needed and much more. This is a beautiful thing explained. Tvak parusya, dryness of the skin, beautifully told. Then decreased muscle tone. This is balya drugs. Because each and everything we are having. So suppose decreased muscle tone is there, balya drugs are there. So suppose Tvak parusya, dryness of the specialty drugs are there. We say Kushtagna drugs are there. Bone weakness is there. We are having different types of drugs are there. For tremors. So all those coin terms are there in Ayurveda. Even for Kesha, for hair fall, we are having a medicine. This is Kesha drugs are there because you will not find such a group of drugs in allopathy or any other system of medicines. So decreased enthusiasm. So some we are having enhancer, cognitive enhancers are there. So you would have I will tell you Vedya Rasayana drugs are there. Centella Asiatica, Shankapushpi, all those drugs are there which are called as cognitive enhancers. Such drugs are there, and we are using such drugs which are giving us a satisfactory result. I am not telling we are getting a beautiful result. No, we are getting a satisfactory results. The patients are happily, the quality of the life of that patient will be enhanced by our drugs. So this is 10 common problems we are getting. 1 minute. So here, 58% of the patients now in India are having hypertension. 47% of the geriatric patients are having cholesterol. 31% of the patients are having geriatrics. In Mysore also, we have done the survey, and the results are like this only. And the beautiful thing here is that 20% of the patients doesn't have major illness at all, where our Ayurvedic intervention can be given to enhance their quality of life. And also we can try to postpone the aging. This is beautiful things. So we have done the survey on adults who are having more than 65 years. These are the types of diseases we got, but 50% of those patients are having both diabetes and hypertension. This is very, 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 very sorry figure for us because it is not at all needed, because these can be prevented if we go with Rasayana type of medications. So what to do if aging is not stoppable? See, can we think about healthy aging? Is it possible for us to think about healthy aging? We have to prepare ourselves. You don't worry about Ayurveda, Unani, Yuddha, Allopathy, nothing. We have to mentally prepare ourselves. After 60, oh, I am aged. That's why the government gives you a privilege. You are a senior citizen. You are having many privileges. So what is healthy aging? Healthy aging is the process of optimizing the opportunities for physical, social, mental health. So decreased, why we should go for this healthy aging? To decrease the mortality rate. 15 to 20% of our population, in 140 crore population, 20% of the population are aged. Decrease in productivity in age group. In future, age group population will be more due to family planning. Medical expenditure per head per month is nearly 6,000. It is according to 1990 statistics. Now I am telling it is more than about 15,000. This is affecting GDP. Later on, it will be burden on the medical system. You have seen in Corona where the hospital put on the no bed board. In future, we will get, without Corona also, we will get this board, because the burden on medical system will be more in 2030 or 2040, wherein 40% of our population will be in geriatric population. We have to think about that. We have to go for a holistic approach. Advantages of healthy aging: promote good health and well-being, healthy transformation of body and harmony, advancement of the phenomena of aging, healthy society, improvise our GDP. Why Ayurveda? This is very, very important. 5,000 years back, they have started. We are having justification. We are having documentation. We are having research advances, research inputs over this concept of Ayu. When I talk about concept of Ayu, aging, we are having two different concepts. I will touch upon this: Hitayu and Haitayu, Sukhayu and Dukhayu. These are very, very important. Nowadays, all the geriatric population is having Dukhayu and Haitayu rather than Hitayu and Sukhayu. If you wanted to have a Hitayu and Sukhayu, try to go for regimen for told in Ayurveda. Dinacharya regimen is there, Rutucharya regimen is there. You are having Vegana Dharana regimen is there, Rasayana regimen is there. Beautifully, for this regimen, you need not go for a doctor. You can practice it. These things have been practiced. If you go to the Malay Madheshwaram hill area, tribal area, 60 years person will look like 30 years. Because he is following the regimen. If you go to the tribal hills of Bihar Hills or Malay Madheshwar Betta or the other areas in Mysore, 60-year person will look like a 30-year person, because he is in nature. He is taking all those regimens. And he will do the regular exercise, he will do the regular food habit, he will not have a cheese ball, or he will not have a manchuri, or he will not have a Domino's pizza, because he is taking the daily regimen according to the prescribed format. Nowadays also you can see in tribal helmets where the lifespan is more than 90-95 years, and 95 years person, you cannot believe he will have the full tooth set. All 32 tooths will be there for him, because he is so healthy. So that's why I said these things are relevant today also. So present day lifestyle, we are on the tablets rather than on the foot. Now we have to change it. Future, tablets should be less. The intervention should be less. So ahara, vihara, vichara, regimens should be followed. Then your tablet thing, the interventional thing, will definitely reduce. Our future should be like this. We have to balance our thing, because we cannot prevent the aging, but we can postpone it. We can give quality of life. Though ancient wisdom, I will not talk about this. Chavana Maharsh's story is there. This is the justification, where after 120 years, he started the intervention of Rasayana and he became egg. I'm not talking that it is possible. No, because these justification, these drashtantas have told, and based on these drashtantas, they said these things, because we have to believe these things. I may not say this is all 100% true. I'm not giving, but they are giving some drishtanta where they will show us a path, a light of path. On those light of path, if we go, we will definitely, I will not say we can halt the aging. No, it is not possible. The Chavana Maharshi tale says that he has halted the aging phenomena. It is not possible now, because I am doing the work for last 30 years. It is not possible for me. I will say it is, I will not say it is false claim, but because of today's lifestyle, because of today's, the potency of the medicine, we are not getting the original medicine now at all. Suppose gooseberry you need, you are not getting a great gooseberry, quality gooseberry nowadays. That's why you are not getting that result. But definitely we can increase the quality of life. This is very, very important. Is that possible nowadays? Yes. With these four principles. One is ahara, that is food, vihara, that is exercise, then achara, then aushadhi. Aushadhi is having last thing. This is why these four principles.
Sir, excuse me.
Okay.
Sorry, we are interrupting you.
Okay.
Actually, we have our USA speaker waiting.
Okay, I will stop here.
No, please, no, you can conclude. It was an excellent talk, but actually it's already 12:30.
Can you give me 5 minutes?
Yeah, you can take 2 minutes, sir.
Okay. I will finish within 3 to 4 minutes.
Yes.
I will skip some of the slides, no problem. So we are having ahara, vihara, vichara, and aushadhi. We are having two important aspects. One is preventive aspect, one is promotive aspect. There are two things are there. So health promotive measures, though we are having Nitya Sevaniya Vichar, because of time limitation, I will not talk about, but I just wanted to speak on this. But just we are having Nitya Sevaniya Hara. This is daily regimen, because I have given anyone who are interested can read this, each and everything as told. Nitya Sevaniya Hara. These things you should not take. Then we are having vihara, what type of daily regimen, night regimen, all those things in explained in chart. I don't want to talk about this one. So then Rutucharya, according to season, you have to follow the seasonal rules and regulations. So each and everything, food, the exercise, how to do it, then vichara, what are the thoughts, then achara, mental attitude. Then we are having the rejuvenating therapy. This is called Rasayana, where we are giving treatment on psychological aspect, social and behavioral aspect, religious and spiritual aspect, and personal aspect, because it is a holistic approach. For A disease, you are having a D drug. No, not like that. So it is an integrative approach, a holistic approach. The references I have given, this is called the intervention. So the intervention in a nutshell. So Rasayana, we are having different types of Rasayana. How it works: improves the quality of body tissues, boosts the immunity, then slows down the senescence, then cures the disease and present recurrences. Then, so Rasayana Karma, so many of the drugs are nutritional based, immunity based, longevity based, rejuvenation drugs are there. So all those things are there. So the methodology is very important: how to use, when to use, where to use. So we are having two schools of thought, where we say one school of thought says start from 60, do the Rasayana therapy. One school of thought says start from 45, because this school of thought started 500 years back. This school of thought started 5,000 years back. When the second school of thought started, the lifespan of the individual was 80. That's why he said start from 45. So it is a continuous process. Rasayana drugs should be taken continuously after 45. That is the rule now. So these are the things, because this is what important here is that at each decidials, 1 to 20, you will lose one thing. At the 1 to 10, you will lose balya. 11 to 20, after 20 years, you will not, your height will not be improved. That is called Vriddhi, cannot be possible. Then Bedha, after 40, you will say, so I am having some problem in my memory. See, each and every 10 years, you will try to lose one aspect, one component of your body. This is what, and for this, you have to go for these drugs. So you are having Ashwagandha, you are having Shakkapushpi, you are having Brangaraja, you are having Triphala, you are having Atmagupta, Amalaki, Brahmi, Bala, all those things according, because this is according to your age. So if you wanted to improve your memory, start the Shakkapushpi or Jyotishmati at the age of 40, because physiologically the memory component will be diminished after 40. So after 60, you will say Chalisa. So your eye problem will start. That's why before that, you start with Triphala, Shatavari, Jyotishmati, Saptamrita Loha, all those drugs are there. If you take it, you can postpone it, but it is not possible to stop it. This is very, very important. This is beautiful concept told in Ayurveda. Each and every 10 years, you will lose something. For that, you have to adopt the lifestyle and you have to take some drugs which are herbal, which are natural, which doesn't have any side effect. Approach to Rasayana therapy, this is the how to give, so what are the components, so state of Agni, Dhatu, Strotas, I have told about that. Then, so persons contraindicated, who can take, who cannot take. So, so what are the, there are different types of Rasayanas are there. So as per health promoting Rasayanas are there. Method of using Rasayanas are there, content Rasayanas are there, Ekamulika, single drug therapies are available. Suppose if you wanted your muscles are not having, you are telling I am having weakness, so go with the Vacha Kashmiriya. So suppose your skin is wrinkled, so you are having Shakkapushpi Jyotishmati, skin health, Brangaraja and Somaraji. There are vision is a problem. You can go for Saptamrita, Chakshusha drugs are there. So these are all the eye diseases, heart diseases, skin diseases, asthma. There are single remedies are there. So these are the single remedies. So then the compound remedies, how it acts. These are the research inputs. That is Emblica officinalis. So gooseberries, we are taking antioxidant and adaptogenic. All those things are there. How it, what are the pharmacological actions? All these are not documented. It is all documented. We are having research updates. We are having research papers on this. That's why I have put it. Whenever I put pharmacological actions, each action has been researched. Updates are available. So all those things I have told, because of time limitation, I will not talk about, I will skip. Then novel approach for adapting, so multiple actions are there. Panchakarma therapy is a must. The cleansing, detoxification of the body is a must. Without detoxification, no treatment is useful at all. So need of contemporary medicine, because why we are talking about Ayurveda today is, it is acceptable, it is valid, it is time tested and culturally viable. What next? Integration. I am not talking only Ayurveda can do it. No, integration is needed. Allopathy, Ayurveda, Yoga, Unani, Naturopathy, Chinese medicine. So integrated approach, social approach, then physical approach, mental approach, then cultural approach, philosophical approach, all the things, because it is a multifaceted thing. All systems are involved here. So all the integrated, because this is the thing told in Government of India 2017 policy, where they have highlighted geriatric care can be solved only by an integrated mechanism. So now we have to join our hands, and I thank Joshi sir, because he has started a beautiful journey of joining the hands. It's a really a great opportunity for me to talk with all pharmacological doyens. I thank Rangari sir for giving me an opportunity. I thank Joshi sir for giving me an opportunity. Parleji sir is there. All other doyens of pharmacy are there here. So I thank the organizers for giving me an opportunity. Thank you, sir. Joshi sir, over to you.
Thank you so much, sir. Yeah, thank you so much, sir. Really wonderful talk to the time scheduled. Our next speaker, he's from USA already. His timing is 12:30, if I'm not wrong. Apologize from our side, sir. Yeah. So I request Dr. Angari, sir, to hand over the certificate, appreciation of the certificate to our today's speaker, Dr. Ellen Chennai. Due course of time, we will send it to your mail, sir.
Thank you, madam.
Thank you. From APSC team, we have giving your valuable time and sharing your wonderful knowledge with us. Next, I request Dr. S.P. Muthukumar sir to chair the session. Dr. S.P. Muthukumar, he is basically a veterinarian from Tamil Nadu. And he did his BBSc from Tamil Nadu and MSc from Kerala, Izat Nagar. And later he his specialization in biochemistry, nutrition, and breeding. He started his career as an assistant professor and hatchery manager at Kerala Agricultural University, Government of Kerala. And he's a technical officer at the Institute of Genomics and for the technical glitches from my side. Can you hear me, sir? Yeah. Dr. Muthukumar, he's more than 50
Dr. Mansadeepa.
Yes.
You can skip, the complete reading of the complete profile. We don't have much time.
Yes.
Both are our very good friends and they are excellent researchers.
True,
Dr. Muthukumar and as well as our Chidambar Murthy. You can introduce in 2 sentences.
Yes.
So that we can give more time to Dr. Ramesh.
Yeah.
Yeah, because he has to sleep also.
Yes.
Sorry, Ramesh.
No problem. Yeah.
Yeah. Yeah. Dr. Kotambali Chidambaramurthy sir, he's to chair the session. He's a bachelor in pharmacy in JSS College of Pharmacy and master from the Government College of Pharmacy, as well as he's a credential of many international and national papers, as well as many journals. Having more 6,700 citations without wasting the valuable time of our speaker, which is already delayed the midnight of time, sparing time with us. Really a great honor to you, sir. Thank you. And over to you, sir. I request Dr. Chidambaramurthy sir to introduce our today's speaker, Dr. Ramesh, to the delegates. Over to you, sir. Please unmute yourself. Murthy sir, please unmute yourself. Okay, I can understand there is the technical glitches. Yeah, please.
Am I audible?
Yeah.
Yeah. Thank you, Ramesh, for accepting the invitation. And as already we are running short of time, I see that Ramesh is working as a senior postdoctoral fellow at School of Dentistry at Oregon University. And he's at it's 12:30 night, Sunday night. So tomorrow morning, you need to catch up with the week's work. So without much ado, I would request you to start the thing. Thank you for accepting.
Yeah.
Please.
Yeah, all the best on behalf of the chairman. Thank you.
Great. Can you see my slides?
Yes, fantastic. Yeah.
Great. First of all, good afternoon, everyone. And I would like to thank the organizing committee for this wonderful opportunity, particularly Dr. Arul Kumaran sir, the principal of KTN College of Pharmacy. Thank you, sir. I hope you are listening to this seminar. Today, I will be talking about developing functional bone tissue in the lab using stem cells for bone regeneration, and then drug screening and also tissue regeneration applications. So what is bone tissue? Let's understand something about bone tissue. Bone is a multifunctional organ that is organized in complex hierarchical arrangements. The dense vascularized connective, this is a dense vascularized connective tissue. This is composed of both living matter such as osteoblast, osteocytes, and vascular cells, and also innervations, nerve cells. And then it also has non-living matters such as organic collagen matrix proteins, as well as mineral components, which is calcium phosphate in the form of hydroxyapatite. As a result, both living and non-living components are crucial to coalesce both the stiffness and toughness of bone, which is important for everyday functions. So how bone forms? Bone tissue forms during the fetus development. Embryologically, skeletal tissues, which are bones, typically derive from the mesoderm of the embryo. Bones including cranial vault, maxilla and mandible, clavicle. These bones form through intramembranous ossification, which is a direct bone formation method where no cartilage model involved. On the other case, we have endochondral ossification, which is an indirect method where the bone forms from a cartilage model. Bones such as skull base, vertebrae, pelvis, and long bones, these bones form through endochondral ossifications. In the next 2 slides, we will discuss more about endochondral ossification as well as intramembranous ossification. As I said before, bone forms from the mesoderm of embryo. And here what we see is the mode through endochondral ossification happens. Bone develops from a fetal hyaline cartilage model. This cartilage then calcifies and a periosteal bone collar forms. And then around the diaphysis, and then mineralization happens. During this period, blood vessels of periosteal bud enter the diaphysis. That leads to primary ossification center. The forming bone moves towards the epiphysis as mentioned here, pushing the cartilage towards the end of the bone. And then at the epiphyseal site as well, epiphyseal site as in the epiphyseal plate as well, bone formation happens. So as we see, the epiphyseal plate reduces as the bone formation happens. So during this process, several growth factors participates, such as BMP2, bone morphogenetic protein for bone formation, and VEGF, vascular endothelial growth factor, and PDGF, platelet-derived growth factors for the formation of blood vessels. They participate during this process. Then we have intramembranous ossification, in which case from the mesoderm, mesenchymal stem cells migrate to vascularized gelatinous extracellular collagen fiber matrix. This is called as primary spongiosa. They then differentiate, these mesenchymal cells differentiate into osteoblast. These osteoblasts form bone in a loosely arranged, immature initial form of bone, which is called as woven bone. Upon maturation of this woven bone, that forms lamellar bone. In lamellar bone, osteocytes are basically buried within that bone. So these bone matrices referred to as trabecular or spicules. So the lamellar bone, which is a much tougher form of bone that constitute of both compact and spongy bone. The natural process of mineralization, mineral formation within the spongy bone is called as biomineralization. So where a lot of minerals such as calcium and phosphate comes to the matrices, and with the help of non-collagenous proteins such as osteocalcin and osteopondin, these proteins facilitate the formation of calcium and phosphate within the matrices in an orchestrated manner. Together, this gives the stiffness and toughness to the bone. So anything goes wrong in this biomineralization process lead to osteoporosis or other kind of bone diseases. Then bone has endogenous capacity for repair. When there is a fracture, bone can heal by itself by simply using the fixture. However, large defects, really large defects, and then severe trauma and ischemia, in such condition, bone healing is very, very hard. Therefore, such condition requires augmentation treatment using autograft bone substitutes. Autografts are nothing but we take a tissue from our own body. So for a patient who undergoes surgery, we take tissue from that patient, then it's called autograft. For bone autograft, the one popularly used for bone graft autograft is iliac crest. I'll show the video that demonstrate how autografts are procured from the patient.
And the skin over your hip will be cleaned. An incision will be made over the anterior iliac crest. And the attached muscles move to the sides. A bone block containing thick outer cortical bone and porous inner cancellous bone will be chiseled out of the iliac crest. A hemostasis pad to stop bleeding will be applied.
However, the limitations of autografts are very insufficient amount of graft available, and also it causes donor site morbidity. And then treatment and also severely impaired function of the treated tissue are the primary limitation. In addition, 1 in 7 complex injuries result in delayed amputation associated with high morbidity, revision surgeries, and also socioeconomic cost. Therefore, alternative treatment strategies should be in place to manage such severe trauma cases. In case as an alternative treatment, growth factors, therapeutic growth factors have been widely used, particularly BMP2, bone morphogenetic protein. However, improper usage of bone morphogenetic protein leads to side effects such as heterotopic ossification. Therefore, we need another alternative, a safe bone-like material developed in the lab for healing bone in severe traumatic cases. And then, can we use engineering strategies to approximate this complexity of bone tissue, such as including different type of resident cells like mesenchymal stem cells, osteoblasts or osteocytes, and then inorganic components and organic components, that is mineralized collagen matrices, and then including vascular network and then innervation nerve, all together makes bone. Can we actually include all this to make a bone? That's a very big question. Integrating all of this in one system is extremely challenging. So in our lab, we have recently engineered bone-like material using collagen hydrogel encapsulated with human mesenchymal stem cells obtained from bone marrow. So collagen hydrogel is nothing but a material that holds water molecule and that acts like gel. And collagen, as we all know, it's a major component of protein of our body. So we collect collagen and then mix these mesenchymal stem cells with this collagen. And then we have developed nanoscale engineering mineralization strategy using a cocktail mineralization media that consists of phosphate calcium chloride, as well as phosphate ions. And then this phosphate that orchestrate the deposition of calcium phosphate that orchestrate mineralization the region of the collagen, thus mimicking the minerals found inside the bone, like the native bone. So our strategy, in our strategy, when we applied our strategy, we tested alizarin rate staining and process staining, and both confirmed a time-dependent calcium and phosphate deposition within the collagen, which is further confirmed by elemental analysis. EDAX confirms the presence of calcium and phosphorus in our mineralized matrices. And this photograph clearly shows how the collagen looks like, and how the mineralized collagen looks like, which is transparent because of the deposition of calcium and phosphate. FTIR data also that phosphate groups of the apatite, hydroxyapatite, and also carbonate in our sample. And then amide 1, 2, and 3 basically comes from collagen that confirm our methodology creates bone-like material while reserving the organic component as well as inorganic component. More importantly, the mineral matrix ratio resembles the mineral matrix ratio as found in native bone. And also elastic modulus, the mechanical property of the mineralized material, significantly increased. And then high resolution electron microscopic images clearly demonstrate how nanoscale mineral deposition happens in the collagen fibril. As we see here, this is non-mineralized collagen where you find no mineral deposition. However, these are like 300 nanometer length and 1.5 nanometer thick collagen fibrils, whereas in the mineralized case, as you can see, calcium and phosphate deposit at the inter as well as intrafibular region at the nanoscale level. And then this is what we found in the native bone. So our methodology can recreate a bone-like material using this nanoscale mineralization strategy. And then we performed osteogenesis gene array analysis to determine osteogenic differentiation of HMSCs loaded in the mineralized collagen matrices. What we found, these are the osteogenic gene markers such as RUNX2, osteocalcin, PDPN, podoplanin, and DMP1, dentin matrix protein. They're highly expressed, significantly increased than control group and equivalent to osteogenic induction medium. Osteogenic induction medium is nothing but that a media that contains dexamethasone, glycerophosphate, and ascorbic acid known to promote bone formation when we culture MSCs are pre-osteoblast in that medium. However, in our mineralized condition, we don't use osteogenic induction medium, but the osteogenic differentiation of MSCs was comparable to osteogenic induction medium. In addition, cells in the mineralized collagen matrix acquire osteocyte-like cell morphology with increased number of dendritic-like protrusion and also with increased protrusion length. This is our mineralized matrices. Dendrites are the unique morphological feature of osteocytes through which they communicate with the neighboring osteocytes, which is very important. So in our mineralized material, mineralized collagen, the loaded MS is actually differentiated into osteoblast and then osteocyte that achieve dendrite-like morphology. Then we asked, without the presence of osteogenic induction medium, how mineralized matrices can differentiate MSCs into osteocytes. And we hypothesized that stiffness of the matrices and also phosphate ions presence in the extracellular microenvironment induce the osteogenic differentiation of MSCs through Rho-ROCK signaling and also adenosine signaling. I will explain real quickly about how this mechanism happens. So in a mineralized collagen matrices, the stiffness of the surrounding matrices is very, very high. And also it has calcium and phosphate ions deposited in the matrices. When the stiffness is high, the stem cells sense the stiffness and therefore the actin polymerization increases. It's basically pulling a strong guy is very, very hard, whereas pulling a weak guy is very, very easy. That's the same mechanism goes here. So when the stiffness is high, cells pull them very hard. Therefore, actin polymerization increases. When actin polymerization increases, Rho activates ROCK, and ROCK activates translocation of YAP and TAS into nucleus, which lead to osteogenic differentiation. In case of phosphate ions, the more phosphate ion is taken up by the cells through phosphate transporter. Once more phosphate ions present intracellularly, that increase the production of ATP, adenosine triphosphate, in mitochondria. Then mitochondria, after the production of ATP in mitochondria, degradation of which leads to the metabolite adenosine, which is released extracellularly. This adenosine is taken up back into the cells through adenosine, A2B adenosine receptor. So in order to prove this mechanism and this mechanism participates in osteogenic differentiation in our system, we need to find the target to block them. So there is one pharmacological active inhibitor small molecule available, which is Y27632. There is another small molecule, which is called PSB603, that specifically target A2B adenosine receptor. So if we block ROCK here and then A2B receptor here, then if the osteogenic differentiation does not happen, that means these two mechanisms participates in our system. So from the figure here, it's an immunofluorescence staining for YAP, which is translocated into the nucleus in a controlled system, and then RUNX2, which is an osteogenic marker. Both are highly expressed in the mineralized system compared to osteogenic induction medium and growth medium. And then YAP, when we use YAP, a ROCK inhibitor that prevented YAP expression, therefore osteogenic differentiation did not happen. That proves ROCK plays an important role. That leads to the participation, the role of mechanotransduction in the osteogenic differentiation. Similarly, when we use PSP603, RUNX2 differentiation reduced, that indicates the role of phosphate and adenosine signaling in our system. So we prove that our system promote osteogenic differentiation of the loaded MSCs, human mesenchymal stem cells. So then we asked question, can our material promote bone regeneration in animals, in real? So we tested the efficacy of mineralized cell-laden collagen microgels for guided bone regeneration. We used a critical sized 8 millimeter critical sized calvarial defect in rats. And then we used 5 different groups. One is empty defect, in which case the rats did not receive any treatment. And then as a positive control, we used BMP2 loaded microgel. BMP2, as I said before, it's bone morphogenetic protein that has shown excellent bone forming ability in the bone defect area. And then as a test group, we had only cell-loaded gel, and then only mineralized gel without cells, and then cell-laden mineralized microgel. That is our interested group. Then we did perform micro-CT imaging at 4, 8, and 12 week. And then what we found was the bone volume in the mineralized cell-laden group, which is here. The bone volume in the mineralized cell-laden group drastically increased than empty defect, and also only cell treatment only. The data is comparable to the positive control, which is BMP2. Mineralized microgel, although it doesn't have cells in it, it still did perform excellent bone formation ability. When we measured the bone volume, bone bridging area, and bone mineral density, our test group cell-laden mineralized microgel demonstrated excellent bone formation in rat calvarial defect model. Then rats were euthanized for histological and immunofluorescence analysis after 12 weeks. H&E, the top one what we see here is H&E, hematoxylin and eosin staining. The bottom one is trichrome staining. Clearly demonstrate the formation of bone in the mineralized cell-laden collagen and also in the BMP2 cell-laden collagen. Whereas empty defect and collagen cell-only group, where we can see a kind of connective tissue, not the bone tissue, immature connective tissue we could see. Mineralized collagen, if we see, the bone formation majorly occurred in the periphery of the implant, not completely. And then we implanted human cells in rats, so we can track our human cells are present in the defect or not. So there is this stain called human nucleus staining. So when we did the immunofluorescence staining, the cell-laden group only have positive staining for the cells present in the defect site. That confirms that our implanted cells were viable. Then podoplanin, which is an osteocyte, early stage osteocyte marker. We did immunofluorescence staining for any cell that expressed podoplanin. And our cell-laden mineralized group clearly demonstrate the presence of podoplanin positive cells all over the defect site. Similarly, when we performed immunofluorescence staining for alpha SMA, it's a smooth muscle actin marker that stains blood vessels. The number of blood vessels formed within the mineralized cell-laden group, our group, is comparable to, is highly significantly increased. These are the quantitative data that shows mineralized cell-laden group is significantly better in regenerating bone. And now we have proven that mineralized cell-laden material can be used for the regeneration of bone. Now, using this artificial lab-made bone, can we use this material for drug screening and also to understand other disease conditions like osteoporosis or osteogenesis imperfecta or cancer metastasis into bone? So these are the hot topic, and we always rely on conventional screening platforms such as 2D culture model or animal model. So now we talk about microfluidics based chip system to use them as a platform for drug screening and also for disease understanding. So as we know here, this chart shows that drug development pipeline and the cost associated with the drug development. As we see, it nearly takes 11 to 14 years to bring one new medicine out of 10,000 compounds in the beginning, with the cumulative cost per therapeutic of $4.6 billion, which is extremely expensive, right? And then if something goes wrong, if the product fails in clinical trial, phase 2 or phase 3, that means the entire money invested is like gone, is waste. So can tissue engineering, microfluidics, and stem cell based technology, can they be used in drug discovery and development while reducing time and cost? So here I will present some of the fabrication technology to develop bone on a chip system to discuss, can bone on a chip system replace or reduce animal use in preclinical studies, basically before clinical trial phases. Then currently drug development and screening depend on the in vitro and in vivo model system before moving forward to clinical translation studies. In vitro models are commonly used. They can incorporate various cell sources, biophysical properties, ECM features, biochemical stimuli, but this system lacks a more sophisticated whole organ culture system. It's not complex, it's very, very simple, which is not ideal for drug screening. On the other hand, in vivo models can recapitulate the human organs and their response to investigational therapies. Restricted by the access to test subjects and the feasibility of probing methodologies and ethical concerns, they might not be accurate models of human tissues. So microfluidics may be the way to go to address these issues. Anyhow, these are like very early budding stage research. And then there is a lot of research going on to develop a completely organ mimicking organ on a chip system. So using microfluidics. So what is microfluidics? Microfluidics based organ chip system can be used as an alternative in vitro and in vivo model. It is nothing but the microfluidics is the science and technology of system that process or manipulate very, very small amount of fluids, like nanoliter amount of fluids, using channels micro level channel with dimensions of tens to hundreds of micrometers. The first application of microfluidics was in analysis. Advantage of microfluidics over in vitro and in vivo models are they are biomimetic, preservation of cell phenotype, heterotypic interactions, increased human relevance, no ethical concerns, also easy of handling, integration of detection and imaging systems, small samples required, and also reagent quantities can be minimal, resolution can be higher, sensitivity is good, and cost can be very low, short analysis time, and also small footprint. So it has a lot of advantages over other methodology like in vitro and in vivo methodology. And here, organ-on-a-chips are microfluidic devices for culturing living cells in continuously perfused micrometer-sized chambers to model tissues and organs' physiological functions. This video is from WIS Institute. It's available in YouTube. This video demonstrates the organ-on-a-chip fabrication and its application in the In this case, they develop lung-on-a-chip system.
A lung-on-a-chip is a microdevice that has the potential to replace animals for the testing of drugs and toxins. The device, which is lined by human cells, mimics the mechanical and chemical functions of a living, breathing lung. With every breath, air enters the lungs, filling and expanding microscopic air sacs. Oxygen is transferred across lung and capillary cells and into the bloodstream. This is also where aerosol drugs are absorbed and where infections and tumors form in the lung. The lung on a chip is crystal clear, flexible, and about the size of a small computer memory stick. But it contains tiny hollow channels created using microchip fabrication techniques. A porous, flexible membrane separates the two channels at the center of the device. The opposite sides of the membrane are lined by human lung and capillary blood vessel cells. This mimics the arrangement of lung and blood vessel cells in the air sac of the lung. Application of cyclic suction in side channels makes the entire flexible sheet and cells stretch and relax rhythmically, just like our lung cells do when we breathe. In the lung on a chip device, air flows over the top of the human lung cells, and a liquid medium containing human white blood cells flows below the capillary cell layer. To test how well the lung on a chip device replicates the natural responses of living lungs, we introduced bacteria into the air channel to mimic an infection. And we introduced white blood cells to the blood channel. We then saw the white blood cells migrate across the capillary cell layer, through the pores of the central membrane, and into the airspace where they engulfed the bacteria. Here's a video that shows this response in real time viewed through the device. The tissue cells are not visible here, but we can see white blood cells flowing freely in the capillary channel of the device, just as they do in blood vessels of a healthy person. But when we infect the air channel by adding bacteria, the immune cells abruptly stick to the surfaces of the capillary cells on the opposite side of the membrane, located directly below the infection site. Here is a magnified view showing a migrating white blood cell making its way through the first capillary cell layer, wriggling through the pentagonal hole in the flexible membrane, and then moving out of focus to the other side. When viewed from the air channel, with all cells visible, you can see a round white blood cell popping up from below. Just like in a real lung infection, the white blood cells, which are now colored red, engulf and kill the clean bacterial invaders. The lung on a chip can also mimic the toxic effects of airborne nanoparticles on the lung. In fact, experiments with the device led to the prediction that breathing increases their absorption into the bloodstream, and this has been confirmed in animal studies. Bio-inspired microdevices that can mimic whole human organ function, such as the lung on a chip, could potentially replace animal testing and bring new therapies to patients faster and at lower cost in the future.
So based on the video, what we have seen, we have developed a bone on a chip system using major living matter of bone, which is osteoblast, human mesenchymal stem cells, and endothelial cells in the mineralized matrices. Schematically illustrated here, HUVEC, MSCs, and osteoblast cells are mixed in a biomaterial composition of collagen and fibrin, mix them together and loaded in the device in the middle of the channel. And then you have media channel, the red one that shows here, that will access to add the media to allow the perfusion. And we culture this device after we loading cell-laden gel for 2 days in EGM media, endothelial growth medium, that promote vascular network formation, blood vessel formation. So we observed a beautiful blood vessels formed in the chip within 2 days. Then we moved on to our nanoscale mineralization media that consists of collagen, osteopondin, calcium chloride, and potassium phosphate. Then the system was allowed for incubation under the rocker for 2 days. And then we characterized the system. The system yielded vascularized bone-like tissue on a chip. As we see from here, this is our chip, the central channel loaded with cell-laden gel, and then the side channel were used for media perfusion. And our system is biocompatible with more than 80% cell viability. The cell-laden matrix is mineralized. This is the test group that we tested. This is non-mineralized. This is osteogenic induction medium group. When we tested for alizarin red and one co-sustaining, we found mineralization formed successfully in the mineral system. Moreover, osteoblasts, the loaded osteoblasts, were differentiated into osteocytes as confirmed by PDP and podoclanin, and DMP1, dentin matrix protein. Both are osteocyte markers and their quantification. So this confirms the development of bone on a chip system. In addition, we used MSCs that differentiated into pericytes with endothelial cells to form blood vessels within the chip. This chip is literally 100 micrometer. That means on an average, human hair thickness is 100 micrometers. So this is literally the human hair thickness. That is the chip of the size of the dimension of the chip. So we then characterized using immunofluorescence staining for alpha smooth muscle actin, and then CD31 to confirm the presence of blood vessels. And we see a perfusible blood vessel formed within the chip system. And then this system, can they be used for drug screening? To address that question, we used a currently developed, recently developed EN1. It is a dual acting drug we used that is being currently investigated. This molecule EN1 consists of bisphosphonates, which is a group of medicines that slow down or prevent bone loss, thus strengthening the bones. So bisphosphonates nothing but they inhibit osteoclast activity. Osteoclast, which is responsible for breaking down and reabsorbing minerals such as calcium from bone. The process is known as bone resorption in bone remodeling process. So when we treat EN1 in our system, the DMP1 and DMP1 expression, PDPN expression increase that source. This drug is active in preventing bone loss as confirmed by here. By this immunofluorescence staining. So this proves that the system can be used for drug screening. And this is the last one. Now, we also wanted to understand how bone prostate cancer cells metastasis into bone. So cancer forms somewhere in part of the body, like prostate cancer in the prostate or in pancreas. And then at the late stage, those cells escape from where they are, and then they reach the bone, which is called bone metastasis. So to understand what causes that or how that happens, we did use our platform to understand that. So we prepared vascularized bone on a chip system, as I discussed before. Then we introduced prostate cancer cells by the media channel. And we found that the one in red color is stained for PC3 cells. So PC3 cells migrated through the blood vessels and they start to extravasate into the bone matrix does prove that there are paracrines or some kind of activity that promotes cancer metastasis in our system. So we hypothesis that migrating prostate cancer cells extravasating to the bone matrix attracted by paracrine factors, and upon extravasation, stiffness of the nanomineralized fibers puts cancer in overdrive. When they metastasize, they become super powerful. That's how cancer cells proliferate much faster in an uncontrollable manner. So this is an ongoing study. We have been understanding how this system can be further used to understand the mechanism of bone metastasis of different type of cancer. In our case, we test prostate cancer. So with this, and I'd like to conclude. In summary, we have developed bone mimicking cell-laden mineralized collagen matrices that has potential to use for bone regeneration, to understand cancer studies, cancer metastasis, and also osteoporosis and osteogenesis imperfecta, which is a genetic disorder. And also our system can be used for drug screening. With that, I would like to thank my lab, Dr. Bertasoni, and my lab mates and School of Industry, seed grant, and NIH, funding from NIH and ADCR. And thank you for listening. And I'm happy to take any questions if you may have.
Yeah, it's a wonderful talk. Yes, over to you, Sajjan. Murthy sir and Muthukumar sir, you can take over the question and answer session. It's really a wonderful talk, very informative. A lot of new things we have learned about the regeneration of the bone tissues. Thank you so much. Over to you, sir, Murthy sir and Muthukumar sir. I request Dr. Murthy sir to unmute and continue the questionnaire session. As well as I request Muthukumar sir to join. Technical team, please take the lead for the unmuting of the chairs of the session.
Yeah, Dr. Ramesh, it's very nice to hear your talk. It's very wonderful. Actually, the organ on a chip is one of the modern technologies which is coming as alternative to in vitro and in vivo model. And overall, your coverage is very nice. And I have no questions. Maybe in the chat box, if there is any questions, we will look into. As I could see, there is no questions. And also, due to shortage of time, we may wind up with the permission of Chidambaramurthy.
Thank you.
I think technical team have to unmute Dr. Murthy sir. Meanwhile, with the curiosity, I'm raising the question to Dr. Ramesh. What are the difficulties in generally you come across with this when you go doing for targeting the cancers with this model system?
Yeah, when we talk about cancer, it's like hundreds or thousands of complexity there. And what we try to touch is like 1 or 2 or 3 components out of that hundreds of components. So in our case, we choose bone, which is not like a complete bone, but we try to include as much as possible. And in the same way, when we think about cancer, there are so many thousands of microenvironmental factors involved. But what we do, we just pick the cell and then introduce by avoiding the entire physiology that happens in our body. So for an example, pancreatic cancer, it's somewhere in the pancreas, but that reaches to bone, how? Through physiological system. But that one is bypassed in our system, right? So we directly introduce. So these kind of difficulties, But as the system is improving, we can include each of these components to meet the complexity of the native system. That's the goal. So as I said, it's a budding research. Having this much at this stage itself is like a great step forward in the field, I think.
Thank you, Ramesh. Again, it was a wonderful brainstorming thing. And what I appreciate is because I've worked on 3D cell models and scaffold development. And the challenge we need to understand here is they're trying to generate bone tissue which has multiple cells. Like it is not a single cell type where they can provide. And there are a lot of challenges. And the approach using the engineering lead is fantastic. And definitely these will have a lot of impact on those who are planning for in vitro research, especially on osteoblasts and working on bone cancer for screening of drugs. And thank you for sharing your rich experience in the midnight. And if there are no questions, once again, I congratulate and look forward for the collaboration. Thank you.
Thank you, sir. Thank you so much. Yeah. Have a wonderful day, all of you. Thank you. Bye.
Thank you so much, sir. Thank you so much. I request Murthy sir to share our token of love for a wonderful speaker of today, with the token of appreciation in the form of a certificate. Dr. Murthy sir to add a few words and hand over the certificate to our speaker. Yeah. Unmute, please. Unmute, please. Kindly unmute the technical team, please unmute Dr. Murthy sir. Perfect. With your permission, Dr. Murthy sir, I'll add up. I can understand. So apologize, there is a technical glitches again with a team. Hope you can hear me, Dr. Ramesh.
Yeah.
Yes. Thank you so much for being with us today. The patients waiting, actually, I can say the early morning hours of a day, we giving us time and sharing your wonderful ideas with our delegates. Really, it's delighting and overwhelmed with your presentation. So please take this appreciation of certificate from APSC. Be connect with us, and the coming up days, your contribution have to be taken up to.
Yeah, definitely. I think we lost you. Thank you so much. I appreciate it. And once again, thank you for this opportunity to share the upcoming research with our fellows. So thank you again. Yeah.
Thank you. And again, now to and Dr. Alkumaran sir, you can share a few words. Dr. Alkumaran sir. I think technical team have to be taken role here.
Am I audible, ma'am?
Dr. Alkumaran?
Yes, sir. Yeah, I can hear you now.
Yes. But
ma'am, actually, instead of saying he is my student, I can proud to say I am his professor. So Ramesh is such a kind of personality, and he did the B.Pharm from the Institute College of Pharmacy where I was working. Thank you, Ramesh, for your in-detailed information of your own area of interest, and my kind regards to your daughter and your wife too.
Yeah. Thank you, sir. All your blessings. I really thank you. Appreciate it. Yeah.
Thank you. Thank you, Ramesh. It's a wonderful session.